Good morning, everyone. It is always a pleasure and privilege and very nostalgic actually for me to present at AFPA. Way back in 98, before I started my practice, the first talk I gave as an endocrinologist in Gujarat was with the AFPA, and I talk about thyroid function test. So, in spite of giving so many talks at a national and international meetings, AFPA is always very close to my heart as a family, and the first one to give me the opportunity to talk. So thank you, thank you. So as we are running short of time, I will try to finish in 15 to 17 minutes. So couple of minutes, if chairpersons allow, we can have quick questions. So what I will be discussing is one of the most common tests which we ask for nowadays in our routine practice is the thyroid function test. And it is very important for us to interpret the thyroid function test because usually it is very straightforward. It is one of the simplest tests to interpret, but sometimes there is a conflict between what we see and what we suspect and what we get in the thyroid function test. So if we don't understand some of the finer details how to interpret the thyroid function test, there can be some clinical consequences which requires unnecessary medications, investigations, or a diagnosis. So we'll try to see. We all know that thyroid is controlled by the hypothalamus and the pituitary. Hypothalamus would secrete the TRH, which will stimulate the anterior pituitary to secrete the TSH, and thyroid would produce the thyroid hormone, what we call the T3, T4. And there is a negative feedback by which pituitary and hypothalamus knows how much thyroid is produced and secreted into the blood, and if it is in excess or in a less, it will regulate the TSH or the TRH. And we all know very well, if you ask to do only one test in thyroid function test, I will do only TSH to reduce the cost specifically, because TSH is the most sensitive barometer of the thyroid function. Every slight decrease or increase in FT4 would reflect into significant change into the TSH. The first and most significant change would occur into the TSH before actually T3, T4 changes. So even 2 to 3 fold decrease into T4 would lead to more than 100-fold increase into the TSH values. So which thyroid function test to ask for? If you have to ask only one test, invariably only TSH. Second question comes, when to ask for the thyroid function test. Many labs also say that come with 8 hours fasting. There is no need of a fasting now with any test except for the fasting blood sugar actually. Even lipids we don't need to have the fasting. So no need of fasting for thyroid function test. Many times laboratory will give that T3, T4, TSH. They will recommend that, okay, you ask for the free T3 and free T4 because TSH is borderline. Absolutely, though it is a active hormone, it reflects the actual status of the thyroid hormone into the blood. But FT3, FT4, not only in our country, even in the most developed countries like USA, is not accurately measured many of the times. So we really don't need to have the FT3, FT4 except for the pregnancy and the patients, rare patients with a protein homeostasis changes. Otherwise, T3, T4 are good enough. Even if during the pregnancy you want to do and interpret the thyroid function test using T3, T4, TSH, you just see T3, T4, what is the lab upper normal values, up to 1.5 times upper normal value of total T3, T4 is normal during pregnancy. So even during pregnancy, you may not ask for the free T3 and free T4. So many times subclinical hypo or hyperthyroid patients may not require to spend money and a second testing specifically to do the FT3 and FT4. Which is the best method to measure the thyroid function test? When I started my practice, radioimmunoassay was the only gold standard, which is still the one of the good assays, but it requires a very careful daily calibrations of the assays. And now with the more reliable assays like immunoradiometric assay, immunofluorometric assay, immunochemiluminescence assay, and immunoenzymometric assays, we can have the ultra sensitive TSH. What we need in a TSH is to be very accurate. It should differentiate between 0.1 and 0.05. That is the sensitivity. And now most good labs do the ultra sensitive TSH where you can detect up to 0.05 difference into the TSH values. So there is absolutely reliable to have the ultra sensitive TSH using the modern methodology. What is the role of thyroid microsomal and thyroglobulin antibodies? Because that is again among the package, many times people do ask for or do get the thyroid microsomal or the thyroglobulin assay. There is no need in all hypothyroid patients, okay, because many times we come across a patient who is hypothyroid with a elevated thyroid microsomal antibody, and everybody is panic because the TMA values are very high, more than 500, 600, 1000. Patient is worried, doctor is worried, and it is like a dustbin stuff for many clinicians. They go to dermatologist, feel skin problem, your thyroid is normal, your antibody is very high, that's why you are not getting enough response to my medication. And you go to Parag bhai and ask him to bring down the TMA to the normal values. They go to the gynecologist for infertility, pregnancy loss. They will blame that, okay, your TMA is very high and you bring it down. TMA is just a marker. And I always tell my patients that my TMA is very high. I am worried, my TSH is normal, my thyroid function is normal on a treatment. I always said I will be surprised if your TMA is not within the higher range. All hypothyroid practically, as 90% of them have Hashimoto's thyroiditis, and they bound to have the high TMA, and that will remain high for many years or sometimes decades also. So there is no point in chasing the TMA values and try to bring down TMA to the normal levels. Yes, initial periods, yes, if the TMA is high, you may need to alter the dose of medications more frequently, because what TMA measures is the quantitative immune response to the thyroid antigen. It may not be qualitative. Sometimes TMA is very high and TSH is very borderline. And sometimes TMA is not that high and TSH is 100, because that is what the body also would respond differently. So if the TMA is high, what initial couple of years, probably you need to have the more frequent monitoring of the TSH, maybe every 2 to 3 months till the dose is settled. After a couple of years, most of the thyroids are very stable and you don't really need to keep on monitoring the TMA very frequently and ask the patient to spend money, and sometimes the stress of having an abnormal value always creates a stress. Some indications of having a TMA is euthyroid goiter, where you want to know that, okay, it is the euthyroid patient, but it is the enlarged thyroid is because of the autoimmunity. Subclinical hypothyroidism, whether to treat or not, whether to keep it how frequently under observation if you are not treating, or if you are treating. Infertility, yes. Recurrent pregnancy loss, because there are some indication if the TMA is high, you have to be extra careful. And sometimes there is a role of LT4 if the patient has a infertility going for the assisted reproduction or the IVF therapy, or if there is a recurrent pregnancy loss, small dose of T4, even though TSH is normal, is recommended. What is the role of thyroid globulin antibody? Absolutely no role in hypothyroid patients. I have never asked for thyroid globulin antibody from my side in 30 years of my endocrinology. Not a single patient. It is required only in a host of differential thyroid carcinoma patients in a follow-up to see that patient is not getting any recurrence or not. So that is the only indication asking for the thyroid globulin antibody. What is the role of TSH receptor antibody, which has now last couple of years it is available, and we all as endocrinologists are using it. It is an expensive test, costs around 3,500 to 4,000 rupees. So it is responsible for development of the Graves' disease. So that is the autoimmune disease. We know Graves is an autoimmune disease. So underlying response of autoimmunity can be seen by asking for the TSH receptor antibody. It is not required in everyone. We were managing hyperthyroid patient before 3 years also without getting the TSH receptor antibody. Still we can manage. But what are the indications? At a diagnosis, if the TSH receptor antibody is very high, you know that, okay, how much dose patient would need, how would be the maintenance dose for these patients. On a follow-up specifically, when suppose my patient is on a carbimazole 5 mg, many times I give half tablet alternate day also, and now it is a 2 years, thyroid has started decreasing in signs, patient is absolutely asymptomatic. Now I want to stop the medications and I want to know what is the prediction of remission or a relapse. Then TSH receptor antibody, if they are less than 7, most of the time up to 1.5 or 2 is the normal, up to 7 or less with the clinical settings, I am more confident that, okay, this patient I can stop the antithyroid medication. In the first trimester during pregnancy, if the TSH is suppressed, you don't know whether it is because of the pregnancy or it is because of the autoimmunity, then there is a role. So there is a very limited role because it is a very expensive test. We don't do it routinely in our clinical practice, and we don't keep on repeating every 3 or 6 months unless, as I told, when we are planning to stop the medications. So in the first trimester of pregnancy, slightly different. We have to interpret slightly more carefully. Due to rise into the SGH in the first trimester, there will be suppression of the TSH up to 12 to 14 weeks of pregnancy. So now, as a part of the antenatal checkup, TSH is done as a routine checkup because thyroid is very common among the reproductive age group. So many times we come across a patient who is absolutely asymptomatic and TSH is suppressed and gynecologist is worried. They feel that patient is having a hyperthyroidism, but it is the high TSH which occurs, high HCG which occurs normally during the first trimester would suppress the TSH up to 14 weeks. So can then be normal or mildly elevated T3, T4 or free T3 and free T4. It can create confusion whether it is a pregnancy induced suppression or it is a hyperthyroidism. Most of the time, de novo onset of hyperthyroidism is very uncommon during the first trimester of pregnancy. All autoimmune diseases are likely to get suppressed during the pregnancy because fetus itself is a huge antigen, which is a foreign body with a abnormal proteins, because protein is coming from the mother as well as the father. So all autoimmunity starts to get suppressed. So it is very uncommon that somebody first time would have a hyperthyroidism detected during pregnancy. So if the patient has no symptoms preceding to conceptions of hyperthyroidism like weight loss, palpitation, tremors, goiter, it is very unlikely that this is because of the hyperthyroidism. Sometimes you can't do the scan in these patients, but TSH receptor antibody can be of a value because now every pregnancy is very precious. Everybody reads on the Google net and they are worried, sir, I have only one child, I have conceived after infertility treatment. Are you sure that this is a pregnancy induced? Then of course in such type of the patient we can do the TSH receptor antibody, and if it is negative, which is going to be negative in 99% of the cases, for patients and our reassurance, we can do the TSH receptor antibody. If it is negative and no clinical settings, then we can say that you just observe and TSH would be normal after 12 or 14 weeks of gestational is very, very important. Now, second question comes, what is the normal value of TSH during the first trimester? Because many people started believing that TSH of 2.5 is normal during the pregnancy in the first trimester. And there was a recommendation that you start treating a de novo hypothyroid patient if TSH is between 2.5 to 5 in the first trimester. Now people have gone back and people feel that up to 5, if there is no clinical indication, you can consider as a normal and no need to rush for the treatment of LT4. If the first time accidentally detected TSH is between 2.5 to 5, above 5 years, if it is a reliable assay, of course, you have to treat. In hyperthyroid patient with pregnancy, what to do? Try to keep free T3 and free T4 near upper limit of normal, not to keep the T3, T4 in the mid-normal or a lower normal range. It is always better to give the minimum possible dose of antithyroid medication during pregnancy. And as I mentioned, because all autoimmunity does suppress and hyperthyroidism specifically, most of the patients have a decrease in the dosage, unlike in hypothyroidism, because hypothyroidism gland is not functioning and demand is more. So sometimes you have to increase the dose. Hyperthyroidism, most of the time during pregnancy, you have to decrease the dose, and after second or third after end of the second trimester, sometimes we can stop the antithyroid medications also, which is very, very common practice actually if the requirement of the antithyroid medication is not very high. So which are the conditions where TSH alone might not be sufficient? Very uncommon, central hypothyroidism, isolated or a part of a pituitary disorders. So if you see 1000 patients, only 2 or 3 would be having a central hypothyroidism, and they will not have isolated central hypothyroidism usually. They will be part of the pan-hypothyroidism. So you may not miss a commonly, if you are doing only TSH, the central hypothyroidism. Non-thyroidal illness, specifically in the hospital setting and the ICU setting, only TSH may not be sufficient. Recent treatment for thyrotoxicosis. If the patient is having hyperthyroidism and you are treating with the antithyroid medication, TSH will remain suppressed for a long period of time. axis will take sometimes 6 months to a year to become normal. So if the T3, T4 is normal and patient is clinically better in hyperthyroid patient, just suppress TSH is not an indication to increase the dose. That is what we see in our routine practice. The TSH is suppress, and people are increasing the dose of antithyroid medications. You have to see T3, T4 in such patients. So hyperthyroid on treatment, specifically, you have to do the T3, T4 and TSH, and you cannot do just with the TSH. Hypothyroid patient on treatment, yes, you can manage only with the TSH. You may not need T3, T4. And resistance to thyroid hormone, it's very, very uncommon. In my practice of 30 years, I have not seen more than 10 patients. So it is absolutely uncommon to have the thyroid hormone resistance. TSH secreting pituitary adenoma, where there is a adenoma into the pituitary which secretes the TSH, and because of the increase in the TSH, T3, T4 also would be elevated. Again, in 30 years, I got only 7 patients who had a TSH secreting adenoma. So it's again not a very common. So most common, you do TSH. TSH is normal, forget everything. TSH is high, you do T3, T4. T4 is low, patient is having hypothyroidism, normal, subclinical hypothyroidism. Whether to treat or not to treat will depend upon the indications of why you want to treat and what is the level of TSH. If the TSH is more than 10, you have to treat. If it is between 5 to 10, somebody planning for a pregnancy, infertility, growing child, you may treat. Goiter with a very high antibodies, you may treat. Otherwise, you can observe. If the TSH is low, T4 is normal. It is a subclinical hyperthyroidism, not as common as subclinical hypothyroidism. But again, subclinical hyperthyroidism in elderly populations with high cardiovascular or osteoporotic risk, you have to treat. Somebody young, you can just observe. Make sure that patient is not having a thyroid, subacute thyroiditis. Low TSH, high T4, patient is having a hyperthyroidism. So what are the pattern of thyroid function test? Normal T3, normal TSH, you forget patient is euthyroid. Low TSH, high T3, T4, low T3, T4, high TSH. Most common, hypo and hyperthyroidism. Hyperthyroidism, most common is a Graves, occasionally toxic multinodular goiter, toxic adenoma, where there is a single nodule palpable on thyroid examinations. With hyperthyroidism, you go for the thyroid scan, nuclear medicine. If there is a hot nodule, after euthyroidism on medical therapy, you just give radioablation, patient will become euthyroid. Some drugs like amiodarone, except T4 injection with a hypothyroid patients, pregnancy related and congenital hyperthyroidism. Hypothyroidism, Hashimoto is the most common, occasionally post radioablation or post thyroidectomy. Some phases of thyroiditis, radiations. If the T3, T4 is normal and TSH is suppressed or TSH is elevated, then there is a subclinical hypo or a hyperthyroidism. If the T3, T4 is below normal and TSH is normal or a decrease, patient is having a hypothyroidism because of the central reasons like panhypopituitarism or isolated TSH suppressions. Or if the T3, T4 is elevated and TSH is normal or elevated, there is a most likely to be having a lab error or sometimes, as I mentioned, with the TSH secreting adenoma. So there are some few cases will just give us idea where you have to be careful. 61-year-old male admitted in ICU, type 2 diabetes, developed acute inferior MI, thyroid function test was done and TSH was on the lower side of normal and FT4 was below normal. So whether patient is having a hypothyroidism, central, no, it is what we call the euthyroid sick syndrome or non-thyroidal illness. So relatively common finding in acute or a chronic illness, more common in the acute ICU setting. Absence of intrinsic abnormality of hypothalamic pituitary functions. Avoid testing unnecessarily in a critically ill ICU patients. You may find a low T4, low T3 and normal or a low TSH. Unless there is an absolute clinical suspicions, don't do thyroid function test in an ICU setting. It will be pre-illness if the patient has symptoms or a normal thyroid function test, we are reassured, and thyroid hormone replacement is not required in such patients. Once the patient is out of the acute illness, later on you can do the thyroid function test and most of the time it will be normal. And this is the mechanism by which during acute sickness, there is a decreased activity of the D1 and the D2 activity, leading to low T3, low T4. We don't do the reverse T3 values, but if you do the reverse T3, it will be elevated. So low T4, low T3 is very common. Majority of the hospitalized patient would have a low T3 concentration till they are ill, and some of them would have a low T4 also. So if you don't interpret the thyroid function test properly, you can have the unnecessary LT4 prescriptions, TRS stimulation test, thyroid scans, anti-thyroid medications. So you have to see the clinical context before you interpret the thyroid function test in a small subset of the patients. The second case, 63-year-old female, multiple sclerosis, high FT4, high FT3 and low TSH. So apparently it will look like a hyperthyroidism, but patient don't have any symptoms to explain such a high FT3, FT4 values. Patient has not lost weight, no tachycardia, no palpitation, no diarrhea. So patient is on 300 mg of biotin per day for this multiple sclerosis, and biotin interferes with the thyroid function test assess. So if you do the B12, B12 also will be significantly elevated. So biotin now is very common among the dermatologists. Actually, they give biotin for the lots of skin and the hair problems. So when you interpret the thyroid function test, at least ask whether patient is on any dermic treatment or any treatment where the biotin ingestion is significantly high. So if you stop for even 24 hours and repeat the test after 48 hours, that can become absolutely normal. So you don't really need to wait for a long time. If there is any suspicion, you can always repeat after stopping the medication for even 1 day, and after 2 days, you can repeat the test. Drugs then can lead to alterations in the thyroid function. Lithium, used commonly by the psychiatrists, can lead to hypothyroidism. Amiodarone, used by the cardiologists, can lead to hypo and occasionally hyperthyroidism. SSRI antidepressant can increase the TSH value. Estrogens would increase the thyroid binding globulins and decrease the FT4 value, but fortunately TSH would not be affected much if the patient is on estrogen. So oral contraceptive pill patients, actually if you do the TSH, you don't really have to worry about it. Androgen and the steroids would decrease the TBG and increase the FT4, but again the TSH would not be greatly changed by giving the corticosteroid therapy. This is a 77-year-old female, hypertension on amyloidone, had a fracture hip. Patient was given, because of the AF, was given heparin as a preventive. Patient was euthyroid, no goiter, TSH was normal and FT4 was elevated. So because patient has atrial fibrillation, people would consider that okay, high T4 is responsible for the atrial fibrillation. But you can see here TSH is absolutely normal. So it is because of the heparin actually. Heparin would lead to increase into the free thyroid hormone levels. So 69-year-old lady, thyroid TSH is normal, FT3, FT4 is elevated, TPO is high and patient has a atrial fibrillation. What is the diagnosis? Patient has a high FT3, FT4 with a normal or high normal TSH. So patient has some central disease. So patient has a TSH secreting adenoma or resistance to the thyroid hormone. How to differentiate? If you can do elevated alpha subunit to TSH ratio, some labs do it, then it will be elevated in the TSH secreting adenomas. But more common, if there is a suspicion, you do the pituitary MRI, will show the tumor, and most of the time it will be a large tumor, raised sex hormone binding globulin. If there is a resistance, there will be normal alpha subunit, normal pituitary MRI, normal SMBG, and there will be a family history. But as I mentioned, resistance to the thyroid hormone and the TSH secreting adenoma are not very common clinical situations. So if there is a discordant TFT, you consider age. Again, elderly populations, as you age after 65 or 70, your TSH is likely to go on the higher side. Okay, so if somebody is 70-year-old age, TSH is 7 or 8 or even 10, you don't stamp somebody as a subclinical hypothyroidism even though antibody is positive. It is a body's adaptation to the changing physiology, and it is mentioned that those who have more than 80 years of age, if the TSH is on the higher side, longevity is actually more. So after 70 years of age, TSH is bound to go on the higher side. After 80, up to 15 TSH, if there is absolutely normal T3, T4 is absolutely normal. So you don't jump to the conclusion that okay, somebody is 75, TSH is 8 or 9. Because of the age, they are weakness, tiredness, letharginess, some edema, all suggestive of hypothyroidism. Don't start treatment. It is more dangerous to treat elderly subclinical hypothyroidism than not to treat. Similarly, neonates would have a high TSH values. Up to 15 is normal, up to 1 year of age. So don't come to the diagnosis patient as a congenital hypothyroidism. So neonate and the elderly, pregnancy, as I mentioned, there will be change. You ask for the history about the thyroid medications when you interpret the thyroid function test. About the medications, specifically lithium, amiodarone, heparin is the common, and you just see for the non-thyroidal illness. If the patient has no goiter, patient has a fever, now after COVID specifically, we are seeing lots of subacute thyroiditis, which was there prior to COVID also. But after COVID, we have seen huge number of the patients who had a viral thyroiditis. Patients, every normal individual have had 3 to 4 weeks of the thyroid hormone stores in their thyroid gland. And there is a viral inflammation which damages the thyroid cells, which leads to the stored hormone release suddenly, and there will be features like hyperthyroidism, where T3, T4 would be elevated, TSH would be low, decreased, and patient would have lost weight. All hyperthyroid symptoms would be there. What is the indications? How to go ahead? You just examine the patient, ask for the pain in the neck. If you get a patient who has a neck pain, upper respiratory infections, thyroid tenderness, then patients are having a acute or subacute thyroiditis. Best way is to get the thyroid scan done. Thyroid scan in hyperthyroidism would have a increase into the radioactivity. While subacute thyroiditis, there is a patchy distribution. You cannot really see the thyroid gland, what we see normally in a thyroid scan on a normal hyperthyroid patient. So non-thyroidal illness, and then reassess the thyroid status, whether patient is hypothyroid, euthyroid, or the hyperthyroid test.
Sir, your time is over.
Yes, I'm just finishing. So this was a brief overview about how to interpret the thyroid function test before you diagnose or you modify the treatment of a thyroid patient. Thank you very much for your patience hearing.